Okay, let's begin. So welcome everyone. Thank you for being here today and for attending our final Gutsy Learning series for the year on managing pain in Crohn's and colitis. So my name is Roshane and I am the Manager of Research Impact Communications at Crohn's and Colitis Canada, and I will be your moderator for tonight. Before we kick off, let's go over some technical details. So this session is offered both in English and French. To access the French audio, click on the interpretation option, which is the globe icon at the bottom of your screen, the Zoom menu bar, and select French language. If you encounter any technical issues, try refreshing your website browser or restarting the Zoom webinar. Alternatively, share your concerns in the Q&A box in the Zoom menu bar, and we'll try our best to assist you throughout the seminar. I would also like to acknowledge the rich history and heritage of Canada's Indigenous people. From coast to coast to coast, we recognize the ancestral and unceded territory of the Inuit, Métis, and First Nations people who call this land home. Through this acknowledgement, we express respect for the traditional territories of Indigenous communities and contribute to the promotion of reconciliation. Next, I'd like to issue a disclaimer. The content in this presentation by Crohn's and Colitis Canada is presented solely for educational purposes only. While the information holds general value, it may not be applicable to specific medical conditions. Online resources should not be seen as a substitute for personalized judgment and care provided by trained healthcare professionals. Crohn's and Colitis Canada does not endorse any external product or service mentioned during the webinar. For those of you joining us today for the first time, allow me to share with you Crohn's and Colitis Canada's promise or commitment with you. Our organization is dedicated to discovering a cure for Crohn's disease and ulcerative colitis. Through research, education, awareness, and advocacy, our organization strives to enhance the lives of everyone affected by these chronic conditions. We appreciate your interest in our organization and hope to make a positive impact in the lives of everyone affected by IBD. Next, I wanted to share a platform that recently launched by CCC. If you or someone you know is living with Crohn's disease or ulcerative colitis, we invite you to explore our Crohn's and Colitis Connect platform. It is an online community that offers the opportunity to engage with individuals who understand the challenges of living with inflammatory bowel disease, providing a platform to seek advice and understanding. Next, you can find more details about upcoming events listed on the screen here, either by registering for them at crohnsandcolitis.ca or by scanning the QR code shown on the screen. So before we begin our session on managing pain in IBD, please complete the poll that will pop up in your screen in about 2 seconds, and I'll give everyone about 30 seconds to answer. So just give me a second, and I will launch that. Okay, I'll end the poll now. Okay, thank you for doing that. And we'll also ask you to answer the same question again at the end of the session. And now we get to the actual meat of the session. So let me introduce you to our first panelist, Alia, who is here to share her experience with us as an individual living with IBD. And we are thrilled to welcome her to our webinar this evening. A little bit about Alia. She was diagnosed with IBD 16 years ago, and in 2020 decided to become a mentor with CCC to help individuals like her. She also has her own private practice as a health coach since 2017, where she continues to support individuals living with IBD. So from CCC, Alia, thank you so much for being here today and sharing your personal experience with us on such an important topic. Please take it away.
Thank you so much. May I be heard?
Yes,
You can hear.
I can hear
Great.
you.
Okay, thank you, everyone. So I'm excited to be here, and thank you for Crohn's and colitis for inviting me to share my story, specifically in regards to chronic pain. I will share with you some complementary techniques and tools that I have used through the last 16 years since I was diagnosed with ulcerative colitis that helped me a lot, and that I actually enjoy doing these things. They are part of my healing journey. And of course, I don't use them all at the same time. But what I realize is that prioritizing self-care is really key here when we have chronic pain. And making gradual lifestyle changes was key for me and transformational. So, as I said, I was diagnosed 16 years ago and I had very painful symptoms. I had the urgency going, 20 up to 20 times a day, diarrhea, flatulence, fatigue, mucus, blood, you name it. It really affected my emotional, physical, mental health. And I developed eventually some anxiety. It affected my relationships, my work, and my well being, on almost every level. However, I'm here to give you hope with to tell you my story about all the changes that I was able to make and what has helped me specifically managing the chronic pain. So let's start with the obvious ones, which are the dietary changes which I implemented. So FODMAP diet was key for me, and I followed it with an IBD dietitian. It helped me to identify my trigger foods. So I have both IBS and IBD, and I had this constant lower abdominal pain, which was really my main pain for, years, like to 8 years. And I didn't really know where the pain was coming from, right? And it was a daily recurrence and affecting my life. At some point, my doctor even put me on antidepressants, which didn't really help with the pain, but I guess it helped me at the time with my anxiety. Now I'm happy, that I weaned off them, but I'm going to share with you some of the stress reduction techniques that I have used. But with the FODMAP diet, it was very important. Everyone is different. But for me, it was important because it made me realize that grains didn't agree with me, and the pain subsided from an 8, let's say, to a 2 out of 10 when I removed the grains, mainly rice, which I was having every day. And it was my main trigger. Wow, what a difference it made. I started exploring other kind of starches that were safe for me, like the Japanese yams and sweet potatoes and celeriac. And I learned to love them with different recipes. I've also removed the processed sugar and any kind of actually even artificial sugar, processed food, and gluten also through some intolerance tests didn't agree with me, as well as dairy. So my diet is really clean with protein and vegetables and the healthy starches and some fat. But really, it was important to know that the rice was the main culprit. And also, I've integrated homemade bone broth, which is really soothing for my pain. Turmeric and ginger shots with pepper and lemon in the morning, which I do at home, and drink it as a shot. But something also that has helped me a lot is really to learn to be mindful when I eat and chew my food. I literally count 30 to 40 times chewing my food before I swallow it. And that was really a game changer for me. In terms of medication, I'm on Entyvio now. I have a very good gastro. I have failed Humira in the past, and now it's working well for me. And with the inflammation going down, then naturally the pain reduced, right? Naturally. And the other symptoms subsided, such as urgency, flatulence, and so on. I also worked with a naturopath who helped me to get some supplements, but also did a GI map test really to see, to go more into details on what's happening. So, for example, they found that I have SIBO, small intestinal bacteria overgrowth. So we had to do that. And at some point, I had the H. pylori and so on. So it was very important that I stay on top of things with that. And I used CBD also for the chronic pain, which helped me a lot. And I also love essential oils, especially when it comes to doing an abdominal massage that relaxes the digestive system. I just went on YouTube and looked at different methods, and I find it very soothing when my tummy is not feeling well to do. And there's a special technique to do that, with the professional also you can check, but it's very soothing. Heat therapy for me was key. Hot water was my best friend when I experienced pain, and also occasionally Tylenol worked pretty well when I needed it because I can't take ibuprofen. Um, Something I learned also is the hot and cold showers. So cold shower as well, very very good for the muscles. I end my shower with very very cold water, and it was a game changer. So yeah, I also had a team of people, right? Because this is not a disease I want to go alone with. And I made sure, that I have. So reflexology eased a lot my pain in my stomach. I really enjoyed it with the pressure points that are linked to my colon and felt very relaxed. I started also recently acupuncture. I still don't, it's too early to tell the effect, but I've heard very good things. And, I've been also with a therapist. I mean, lots of cognitive behavioral therapy, and that now I can do actually on my own to reframe my thinking, especially, the future tripping and the catastrophizing that I had about the uncertainty of this disease. And, this disease brings a lot of emotions, and it's very important to process them and not to suppress them. So I even process some trauma, including the trauma of being in a long flare for a long time while living abroad, away from my family. So that really helped me to get things up because the gut and mind connection is real. In terms of physical activity, I found something that I really enjoy and doesn't make me feel like I'm working out. I mean, I don't like to go to the gym, it's not my thing. And I found I started playing tennis 4 years ago. And it's funny how when sometimes I'm in pain and I go play tennis, after I finish, the pain goes away. And it helps me a lot with the fatigue to stay active and so on. The other thing is yoga. So I'm a certified yoga teacher, and this, of course, has changed my life. I've been practicing for 25 years. And the nice thing about yoga is there's different kinds of yoga, right? So yin yoga, when I have fatigue before bed, and then I have a yoga sequence for bloating and gas, right? So it helps me to focus on flexibility, relaxation, deep breathing, toning. And it can only be 5 minutes, 10 minutes, 15 minutes, whatever I can do is good. Meditation is amazing. So I use a app called Nerva. So guided meditation, breathing exercises to reduce anxiety and stress management. So, when I'm anxious, I love the tapping, the emotional freedom technique. It's a kind of acupuncture focused on the emotional release. So because we suppress a lot of emotions, especially with the fear, so very important that our feelings come out and we get clarity on them. And another thing is that now I have a very sacred morning routine. So sorry, I'm going really quickly. I'm not sure how much I have left, but maybe 1.5 minutes. Um, my morning routine, right, is consists of, journaling. So that's one of my favorite because, I do it daily and it improves my self-awareness, my self-compassion, letting go of resentment and fear. So journaling my thoughts is really good because I get clarity on what is in my head. And there's a lot of dishonesties sometimes, and I believe things that are not true. Positive affirmations are also super effective. Like when I'm feeling low, I'm feeling pain, I do affirmations like I'm strong and I'm, I can do this. And it encourages resilience and empowerment for me. Meditation, daily gratitudes as well is super important. For me, it shifts my mind, like works like magic for positive aspect, to make my mind more positive. Because this disease can bring me down, especially when I'm living with pain day in and day out. It's like it really can put me down. And practice acceptance, right, of the present moment. Like realize that this is, oh, that's the timer. I'll wrap up. To realize that this pain is not going to stay forever, and trust and have faith that things will be okay. And to be honest, they've always turned okay, through the ups and downs. I've learned to slow down when I need to, and to stop being a perfectionist, and instead focus on progress, not perfection. So that's good. And I've learned to ask for help, right, when I need it, because I was amazed how people around me want to help. But something important I realized is I would go to people who can give me comforting and who can provide it, right? Some people cannot provide comforting, and it's okay. But when I need it, I have to go to the people. So really, in closing, for me, the silver lining is that this chronic pain has taught me to be more grateful, more patient also, more resilient, more present in the moment, more empathetic towards myself, but also and to others, and to practice self-compassion and self-love, which I never had before. And I turned it into a career. I started my business 2 years ago as a health coach to help people who suffer with IBD and guiding them through the techniques and tools that I have shared with you. But I think, yeah, so today, despite the ups and downs and the occasional chronic pain in my life has been transformed. And, overall, I live a joyous life. So thank you for letting me share my experience with you.
That's amazing, Alia. Thank you so much. I really liked what you said about progress and not perfection. And yeah, it's just amazing to see how empowered you sound as you try to figure out different, for yourself, what were the different interventions that helped. And I really hope, I personally believe it's very strong. It's important that we hear both the patient perspective and the scientific perspective when we're discussing complex topics in IBD. And speaking of the science, we will now transition to Dr. Nasser's talk, where she will be talking about pain management, more from a clinical and scientific perspective. And I really first want to thank Dr. Nasser for being with us here today. And we really appreciate you taking the time to share your expertise with us. A little bit about Dr. Nasser. She's an assistant professor and clinician scientist at the University of Calgary. She completed her MD PhD in 2008. She followed that up with a medical residency at the University of British Columbia, and she then further specialized in gastroenterology at the University of Calgary. She then started studying pain, which is what she'll be talking about today, during her postdoctoral fellowship with Dr. Vanner at Queen's University. She also has been the recipient of numerous awards, and the one I will talk about is she, in 2023, received the CCC's Women in IBD Award, which is our own award, highlighting, because she's so amazing and she was nominated by her peers. So we're very proud of that. And she's also the co-lead of the high-risk IBD clinic at the University of Calgary. Again, thank you for being here with us today and sharing your expertise, and please take it away.
Thank you so much, Roshane. Can you hear me all right?
Yep, you're clear.
Okay, so thank you so much for that really kind introduction. So as Roshane mentioned, I'm a gastroenterologist as well as a scientist, and I do run a clinic where I see IBD patients who have chronic pain and who are in remission from their inflammatory disease, but also continue to experience pain. And of course, I have a laboratory as well where we do research into some of the causes surrounding chronic pain. So the objectives today for the talk, if we can move to the next slide, Roshane. I hope to convince you that chronic pain can continue even when inflammation is well under control in inflammatory bowel disease. I'd like to talk to you about how the brain-gut connection or the brain-gut axis is really at the heart of chronic pain in IBD, as Alia has so eloquently discussed in her piece there, and also to talk about some of the treatments for pain, including both medications and lifestyle approaches. So next slide, please.
Oh, sorry. Can you see the slides? They're on.
Yeah, there we go. Yeah. So the main goal of treatment when we as a gastroenterologist diagnose you with either mild Crohn's disease, as you can see in the middle panel, or pretty severe ulcerative colitis, as you can see on the far panel there. The main goal of all of our treatments, whether that's a small molecule, whether that's a biologic, whether that's an immunomodulator, whether that's a 5-ASA drug, the main goal of all of those treatments is to cause mucosal healing, which is the process of repairing the inner lining of the digestive tract, which has been damaged due to inflammation. And the reason this is one of the main goals is this is what all of the therapies have been tested to do in clinical trials. But unfortunately, for many of our patients with inflammatory bowel disease, this is really not the whole story. Next slide, please. So essentially, abdominal pain is very common in inflammatory bowel disease. So during a flare, anywhere from 50 to about 70% of patients actually experience pain. But even when inflammation is fully healed, anywhere from 20 to 60% of IBD patients can still have ongoing abdominal pain. And as you can imagine, this is a very devastating outcome. This can lead to high levels of anxiety, depression, and a very poor quality of life. And the problem is that there are very few good treatment options available, some of which we will discuss today, but that has led to a big problem, and that has led to our patients being prescribed opiates. Next slide, please. So opiates, as many of you know, are painkillers. Some of the names of the opiates you should see are on the slide there. So these are really not the best options for treating pain in Crohn's and colitis because they actually don't work well. And we know that opiates have many side effects, and they're actually associated in IBD with depression, disability, hospitalization, post-operative complications, and death. So these are clearly not the answer, and we really need to do better. Next slide, please.
We're on the prevalence slide of chronic pain in IBD.
There we go. All right. Oh, sorry. We can just go back.
Oh, go back. Sorry.
Sorry, my bad. So I forgot to explain that little graph at the side.
Sure, no worries.
Okay, so this this panel here that you can see in B there, this is a figure that was taken from a study where they looked at the number of patients who have inflammatory bowel disease who are given a prescription for opiates at the time of their discharge from the emergency department. And as you can see, in around the 2006 to 2008 date range, it was around 40%. It did drop to about 30% in the 2015 to 2017 range, but that's still unacceptably high for medications that cause death. So I would definitely say that we need to do better. So we can go to the next slide and then the slide after that. Okay, so now I just want to talk about who really develops chronic pain in inflammatory bowel disease in remission, how many people develop this, and what are some of the risk factors for developing chronic pain in IBD. So this slide shows some data from a study of IBD patients from the Netherlands that were followed up over around 18 months. So this was around 560 IBD patients. And each of the patients were provided with a telemedicine tool so they could monitor their patients remotely. And in this study, the patients were all in remission, and they judged that by looking at biomarkers such as the fecal calprotectin. And in that study, about 46% of their IBD patients over the 18 months reported chronic pain. So that's a really, sorry, that was my child alarm, reported chronic pain. So in another study from the United States, about 60% of patients developed chronic pain over the course of the study. And then there was another study that was just published this year in 2024, and that one was out of I think Belgium, and there they had about 16% of their patients who developed chronic pain. So a big range, anywhere from 16% to 60% of IBD patients are developing chronic pain. So what are the main risk factors? So the Dutch study found that the main risk factors was being female. And I say being female rather than being a woman, because in the Dutch study, they only gathered data on biological sex. They never actually asked patients about their gender. In the Dutch study, they found that patients with ulcerative colitis were more likely to develop chronic pain, but the American study actually showed Crohn's disease. And patients who had concomitant anxiety, depression, or fatigue were more likely to develop chronic pain, and that's also been shown across all the different studies. And patients who have experienced adverse life events were also more likely to develop chronic pain. Next slide, please. So this is a graph from one of the British studies when it comes up, where they kind of looked at what happens to chronic pain symptoms over time. So in the blue, you can see patients who've never had chronic pain. And here they followed the patients up over a period of 6 years, every 3 months. And they showed in the blue that even if you've never had chronic pain at the start of the study, about 60% of patients did develop pain at some point in time over those 6 years, okay? Patients who had pain the whole time at the start of the study, about 60% of them sort of had waxing and waning symptoms. 18% of them stayed about the same, and 18% of them actually completely resolved their pain.
Recording in progress.
Sorry, I don't know what happened there. And one of the things that they found when they looked at these patients throughout those 6 years is that many of their patients developed anxiety, depression, and they really had very poor quality of life scores. Next slide, please. So to recap so far,
Sorry, I think there's a delay.
yeah, there's definitely a delay.
Sorry about that.
That's okay. So to recap so far, chronic pain is very common in people with inflammatory bowel disease, females and patients with coexisting psychological conditions seem to be at the highest risk, and chronic pain has several impacts, including poor quality of life. Next slide, please.
Okay, we're at chronic abdominal pain.
So now I'd like to talk about some of the causes underlying chronic pain in inflammatory bowel disease. So when I see a patient who's referred to my IBD chronic pain clinic, the first thing I have to ask myself is there chronic pain secondary to active disease? Is there chronic pain secondary to complications related to IBD or other causes related to IBD? Or is this pain because of an abnormal brain-gut axis connection? Okay, so obviously for active and ruling out active IBD, we ask the patients to get us some biomarkers, things like a C-reactive protein, a fecal calprotectin. We might get some endoscopy. We might look at imaging studies like a CT scan, an MRI, or even a bowel-specific ultrasound if that's available in your center, in our center, that's available. And then I do think about IBD-related complications that can cause pain, things like abscesses, fistulas, strictures, infections. And then other causes that can be related to IBD, so poor nutrient absorption. So we know patients, for example, who've had a resection of their terminal ileum don't absorb bile acids as well. Patients can get small intestinal bacterial overgrowth if they've had a previous surgery. Patients can get pelvic floor issues. There could be side effects from medications or other concomitant illnesses. But if we rule all of those things out, the pain may actually be secondary to a disorder of the brain-gut axis. Next slide, please. So the brain-gut axis is essentially a communication loop between the brain and the gut, okay? And there's...
Is everything okay?
Yeah, no, I just don't see the next slide, sorry.
Oh, we're at the brain-gut axis slide.
Okay, all right. I'm just not seeing that. Okay, no problem. So essentially, there's the brain, okay, and there's the nerves that go from the gut to the brain and the brain to the gut. So these red nerves here are those that communicate pain, and they project from the gut to the brain. And these blue nerves here are those that actually dampen pain, and they project from the brain to the gut. Now, in chronic pain conditions, these red nerves that communicate pain signals to the brain are really excited and they're revved up and they're firing more and more often. And that's interpreted at the level of the brain as pain. And these blue nerves that normally dampen pain don't work so well in chronic pain conditions. We also know that there's changes at the level of the gut. So in the gut microbiome, for example, that contributes to pain. We also know that there's changes in hormones that go from the brain to the gut and the gut to the brain that can contribute to pain. And we know the brain is very different. So things like stress, anxiety, depression, expectation of pain, these things don't cause pain, but they change how pain is processed at the level of the brain. So if I have a patient who's stressed or anxious and I do a functional MRI of their brain is going to look very different when they're stressed and anxious versus when they're not. And so that's because these areas that process negative emotion are also connected to the areas that process pain. And we know that in disorders of the brain-gut axis, like chronic pain and inflammatory bowel disease, this whole axis becomes really overly sensitive to normal signals, and it becomes kind of revved up. And that's a process called visceral hypersensitivity, meaning that there's a lot of sensitivity of the gut to any normal stimulation or normal, even normal things. So for the best example I can give you is, for example, let's say I'm doing a colonoscopy on somebody, right? So I'm doing a colonoscopy, I'm putting in a lot of air, okay? On a normal person, if I put in a lot of air, that person's going to get pain because that air is going to cause stretch of the colon, and that's going to be communicated to the brain as pain. But if I put in a little bit of air, that normal person should not have any pain. But if I take somebody who has visceral hypersensitivity, so somebody, for example, who has inflammatory bowel disease and has chronic pain, and I put in a little bit of air, now suddenly that's going to cause a lot of pain for that patient. So that's how we kind of talk about the brain-gut axis becoming revved up. And so when we talk about therapies for chronic pain and inflammatory bowel disease, we've got gut-directed therapies, we've got therapies directed at the brain, and we've got therapies directed at those nerves that communicate from the brain to the gut and the gut to the brain. So let's first talk about gut-directed therapies. So next slide, please. So this slide just kind of shows you some of the general dietary advice in terms of Crohn's and colitis. So this is just general dietary advice. And in general, in inflammatory bowel disease, unless you have stricturing Crohn's disease, it is recommended that you eat more fruits and vegetables, as can shown there, and more omega-3 oils coming from fish, and decrease the amount of red meat, processed meats, emulsifiers, and ultra-processed foods that you're consuming. Now, in terms of diets, so there's been a lot of interest in the Mediterranean diet, and that's been used for patients in remission, essentially to help them stay in remission. But there's really no data on whether the Mediterranean diet actually helps in pain. Next slide, please. So the main diet that we use in order to treat chronic pain and inflammatory bowel disease is the one that Alia talked about, is the low FODMAPs diet. So what is the low FODMAPs diet? So this is a diet that was designed to be used in irritable bowel syndrome. So this is a diet that's low in fermentable oligodisaccharides, monosaccharides, and polyols. Huge mouthful. Essentially, these are poorly absorbed carbohydrates. So they're not well absorbed in the small intestine. They go to the large intestine where they get essentially fermented. And that causes a lot of gas to be produced. That causes stretch, bloating, which is sensed by the brain as pain. So going on a low FODMAPs diet kind of decreases these gas-forming carbohydrates and has had some success in treating abdominal pain in conditions like irritable bowel syndrome, as well as in patients with IBD and chronic pain. And I'll show you some of that data a little bit later on. Next slide, please. So this is a slide from the Monash group, and that's the group that first developed the low FODMAPs diet. And this kind of tells you how to do a low FODMAPs diet. So essentially, it's recommended to stick with a low FODMAPs diet, i.e. cutting out all the high FODMAPs foods for about 6 weeks, and then to gradually reintroduce defined triggers. And Ali actually talked about that quite nicely. And the reason you need to reintroduce is a few things. Number one, it's a really hard diet to follow. You have to live, so you have to reintroduce. Number two, FODMAPs are actually prebiotics, and they cause the growth of different types of bacteria in the large bowel, as well as the secretion of some products that can actually help the large bowel and maintain a healthy large bowel. So being very restricted for a long period of time, we don't really know the consequences of that. So it's important to reintroduce, and it's important to do this with the help of a dietitian. Next slide, please. So this study is showing you some of the evidence behind the use of the low FODMAPs diet. So this is a diet study in inflammatory bowel disease from the United Kingdom, where they had 88 patients who had persistent gastrointestinal symptoms, which their physician considered to be caused by the absence of inflammation. So there was no biomarkers or endoscopy to ensure that they were in remission. And all of these 88 patients were placed on a low FODMAPs diet. So all of them were seen by the same dietitian. They were provided with educational materials, including resources and recipes. And then 6 weeks later, they were seen and counseled on reintroduction. And as you can see, next click, please. Patients actually reported an improvement in abdominal pain scores, as you can see here, an improvement in bloating, flatulence, nausea, as well as satisfactory relief of symptoms. Now, the one criticism of this study, of course, is that it's not a randomized study. It's just all the patients were placed on the same diet. So then the same group from the UK went on to actually do a randomized control trial. Next slide, please.
It's on the next slide.
Oh, is it? Okay.
Yeah.
So it's on the, okay, there we go, sorry. So this is a randomized controlled trial now from the same group. So here what they did is they enrolled patients with quiescent inflammatory bowel disease, which they defined by physician global assessment, the use of stable medications, no flares for 6 months, and a fecal calprotectin less than 250. So an objective marker in this case of a lack of inflammation. And patients were randomized to either a placebo diet or a low FODMAPs diet. Again, they were counseled by the same dietitian. And the main thing that they were interested in is looking at the change in the IBS symptom severity score, which is a score that's often used in clinical trials that look at abdominal pain. And when they did that, they didn't actually find any statistical significant drop in the IBS symptom severity score between patients on the low FODMAPs diet or the sham diet. But patients did report an improvement in bloating severity, as well as adequate relief of symptoms. So what I tell my patients in clinic is that the evidence is not perfect underlying the low FODMAPs diet in inflammatory bowel disease in remission. There is better data that comes from the irritable bowel syndrome world, but I would say that this diet is generally a low risk diet with 2 caveats. First of all, patients should be monitored and helped through this diet by a dietitian. And it's very important that we are aware of the risks of eating disorders in our patients. We obviously don't want patients to become too restrictive. And there is an eating disorder called the avoidant restrictive food intake disorder. So that's another reason to have patients followed by a dietitian, because dietitians are very, very good at screening for this, way better than physicians. Next slide, please.
We're on the probiotics slide.
So really, there's one of the other obvious things about treating the gut in the gut-brain axis is probiotics. And many of my patients are very interested in probiotic type approaches. The data really looking at probiotics is poor. So I would say in inflammatory bowel disease and abdominal pain, there's really no studies. In irritable bowel syndrome, there is very low evidence for certain probiotic combinations that seem to work. And what I mean by that is that there's always a clinical trial of probiotic A versus placebo or probiotic B versus placebo. And they're always positive, but nobody ever compares probiotic A to B. So what we know is that certain types of multi-strain probiotic combinations seem to work, but the evidence is really not great because they're always tested in very small numbers of patients. I would say that the risk of harm is low. What I tell my patients who are interested in this type of approach is that it's quite reasonable to try one multi-strain probiotic, try it for a month. If it works, that's great. If it doesn't work, don't waste your money going out to buy like number 2, number 3, number 4, number 5, number 6 type of formulations, because there are a lot of formulations and they're very expensive. Next slide, please. So we've kind of talked about therapies that are directed at the gut. So now I'd like to look at therapies that are really looking at the brain and addressing pain processing in the brain. Next slide, please. So Alia already alluded to some of these types of therapies. So this slide just shows some of the names of the different therapies that have been used to treat the brain, and some of the psychological techniques that are used to treat the brain and disorders of the brain-gut axis. So you can see some of the names here. There's psychodynamic interpersonal psychotherapy. There is mindfulness-based stress reduction, which I think, Alia, you were alluding to. There's gut-directed hypnotherapy, and there's cognitive behavioral therapy. And these types of techniques have had actually quite good outcomes in patients with irritable bowel syndrome. And in general, the studies in inflammatory bowel disease patients who have abdominal pain have been positive. Next slide, please. And one of the big reasons we think that these psychological techniques work in inflammatory bowel disease is, unfortunately, our patients with inflammatory bowel disease are more likely to have underlying psychological comorbidities like anxiety and depression. And this is much, much higher than the general population. I read a shocking statistic that about 74% of our IBD patients have experienced adverse childhood experiences. That's extremely high and very shocking. So this is another reason to consider these type of psychological techniques. Patients with inflammatory bowel disease, as Alia alluded to, have very high rates of PTSD, post-traumatic stress disorder, even compared with patients with irritable bowel syndrome, where it's only 26%. And the reason for that is us, right? It's all the medical things that our patients with IBD have had to undergo: multiple colonoscopies, surgeries, long hospitalizations, traumatic starts to medications. All of those things really contribute to this high rate of PTSD in our IBD patient population. Now, I wanted to kind of give you an example of how cognitive behavioral therapy works, looking at this cartoon here. I am not a psychologist, so my explanation is going to be maybe a little bit simplistic. So in this cartoon, you can see, for example, that this patient who's been restricting food so she can go out with her friends, she's hungry. So she experiences some rumbling in her stomach, okay? And then that causes a lot of anxiety around that symptom. And the patient starts thinking, oh, rumbling is bad. Rumbling means that things are moving fast. I'm going to have to go to the bathroom. There isn't one here. There really isn't one. And then she says, I think I better just leave. Nobody understands me anyways. So that behavior is really out of proportion to her symptoms. So what cognitive behavioral therapy does is it tries to stop those maladaptive or those thoughts which are not really helpful for patients. Next click, please.
I've clicked.
And then next slide. So who might be referred for psychological therapies, or who might benefit from psychological therapies? So I think anybody who has, underlying psychological comorbidities like anxiety, depression, PTSD, a history of adverse life events might benefit from this. People who recognize that stress and psychological symptoms seem to contribute to their symptoms or impair coping. Patients who are really motivated are probably the best people to undergo psychological therapies because these are difficult. They take a lot of time. You really have to do a lot of homework to benefit from psychological therapies. People really have to buy into this type of an approach. And of course, it depends on patient preference who wants to undergo psychological therapies. And I have a lot of patients who prefer this type of an approach rather than drugs. Next slide, please. So Alia talked about exercise and physical activity today in her journey. So in terms of looking in the literature about the role for exercise and physical activity, we know that exercise or moderate activity can help reduce the severity or frequency of some of the symptoms of inflammatory bowel disease, such as fatigue. But there's really no studies looking at whether exercise impacts abdominal pain. Next slide, please. One of the exercises, of course, that has garnered a lot of attention and popularity is yoga. And there have been a couple of studies of yoga in inflammatory bowel disease. So they're the ones listed here by Kaur and Pirani. The Pirani study was a joint one done at the University of Alberta and the University of Calgary. So that first study, essentially what they did, it was a randomized control trial of yoga of IBD patients who were in clinical remission. So there was no objective markers to figure out whether they had a small amount of inflammation or not. And those patients that underwent the yoga practice reported less intense pain compared to the control group. In the 2022 study there, what they did is they performed a 12-week online intervention. So they recruited IBD patients who had elevated self-reported stress scores. And these patients were on stable medication doses. So they had both active IBD patients and IBD patients who were in inflammatory remission. And patients either were randomized to a control intervention, and here they got emailed a motivational quote every week, or they underwent weekly follow-along yoga, breathwork, and guided meditation, as well as cognitive behavioral therapy. And the patients who underwent the yoga intervention and the cognitive behavioral therapy showed really improved stress scores and also reported improved anxiety and depression. But there was no change in the inflammation in those patients who had active disease. And that kind of makes sense because yoga acts at the level of the brain, not necessarily at the level of those inflammatory cells in the gut. Now, this cartoon here just shows how we think yoga is working. And I would say we don't quite know how yoga works, but we think yoga practice increases blood flow in the brain, and that increases the activation of centers in the brain like the prefrontal cortex, and that helps to dampen stress and negative emotions. We also know that yoga seems to increase the levels of this inhibitory neurotransmitter called GABA, which also feeds into that. And yoga seems to decrease the activity of an area of the brain called the amygdala, which is involved in processing negative emotions, and also increases neurotrophins, which seem to play a positive role in treating stress. Next slide, please. So now we've kind of talked about therapies which are aimed to treat the gut and therapies that are aimed at treating the brain. So the next place to talk about therapies are those that treat those pain-sensitive nerves that project from the gut to the brain and the brain to the gut. And the main types of therapies we have to treat these nerves are therapies that are called neuromodulators. Okay, and neuromodulators are used to reduce those heightened pain signals. Next slide, please. Many of our neuromodulators actually are antidepressants. So antidepressants come in multiple different flavors. There are SNRIs, there are SSRIs, and there are tricyclic antidepressants. And the best evidence that we have for neuromodulation is primarily for tricyclic antidepressants. Now, people get really concerned when I talk about this in clinic because they think, are you just trying to give me a medication for depression? But particularly the tricyclic antidepressants, they're very old antidepressant drugs. The effective antidepressant dose is 150 milligrams, but the effective neuromodulatory dose is 10 milligrams, so almost 10 times lower the effective antidepressant dose. And these are used at very low doses to change the signaling of those pain-sensitive nerves that project from the brain to the gut. These, of course, do have side effects, but they are extremely successful at treating pain. And much of the data, although there is one study in inflammatory bowel disease patients with chronic pain, much of that data comes from patients with irritable bowel syndrome and is very, very strong. The data behind the use of SSRIs and SNRIs is really not as good. SNRIs don't have a lot of data from chronic pain conditions from the gut, but SNRIs are actually used to treat chronic pain from other sources like fibromyalgia, like TMJ, like chronic pelvic pain. So we do know these drugs actually work as neuromodulators in chronic pain conditions. Next slide, please. Another option to act as a neuromodulator to treat those nerves that project from the brain to the gut and the gut to the brain is actually peppermint. So there is long-acting peppermint preparations or enteric-coated peppermint preparations. And these have shown some modest benefit to treat abdominal pain compared to placebo in patients with irritable bowel syndrome. There's really very little risk of harm. The main side effect of peppermint is heartburn. So I tell patients not to take it at night before they go to bed, otherwise they'll be up all night. enteric-coated peppermint oils can be found over the counter. They are expensive. So I tell patients, look, if you try it and if it works, but it's too expensive for you, just make peppermint tea, but you'll have to do that multiple times a day because it's not going to last for as long as this long-acting peppermint. Next slide, please. Now, in terms of other pharmaceutical agents that have been shown to treat pain in irritable bowel syndrome, like anticonvulsants, secretagogues, like linaclotide, Trulance, Ibsrela, 5-HT4 receptor agonists like prucalopride, or opioid receptor agonist antagonists like Vyburzi. Next click, please. There's really absolutely no data in inflammatory bowel disease, and we do use some of these agents here and there, but it's very much off-label. Next slide, please. So to recap, so far, what we've discussed in this section is that chronic pain in IBD is linked to an overactive connection in the brain-gut axis. And current therapies really target different parts of this connection to help manage pain. But there are very few clinical trials that have tested medications in patients with inflammatory bowel disease and chronic pain. And really, a lot of our therapies are extrapolated from treating patients with irritable bowel syndrome. Next slide, please. So what are we doing about this right now in the lab? And I just wanted to share a couple of things that we're doing in my laboratory in terms of the causes of chronic pain in inflammatory bowel disease. Next slide, please. So my laboratory is really interested in the role of the gut microbiome in chronic pain. As many of you know, we're literally home to trillions of bacteria in our gut. And we know that in patients with inflammatory bowel disease, the gut microbes are different. And we're really interested in looking at whether this plays a role in chronic pain. And one of the things we're really interested in is the sex difference in pain. And as you remember, way back when, at the beginning of the talk, when we were talking about the risk factors for developing chronic pain, one of the big ones that keeps coming up over and over again is being female. So one of the questions that we asked in our lab, next slide please, is does the abnormal gut microbiome in IBD patients play a different role in causing chronic pain in males and females? Next slide, please. So the way we really study this is in a mouse model. So this is the mouse model that we use in our laboratory. So we give our mice a chemical called dextrin sodium sulfate, and that causes the mice to have colitis, which has some commonalities with ulcerative colitis. And then we allow the mice to recover for 5 weeks, and then we evaluate pain coming from the colon. So how do we evaluate pain coming from the colon in a mouse? Because a mouse can't really talk to you to tell you it's in pain. Next click, please. So the way we do that is a test called colorectal distension. So just like in a patient, okay, we put a little balloon inside the colon and we inflate it, okay? And then we look at the musculature of the mouse and we're looking for splinting of that abdominal musculature. So just like if I was to do a colonoscopy on one of you and I was to put in a lot of air, you wouldn't like that, right? So this is the same thing that we're looking at in the mouse, okay? So in this model that was developed where you give the mice dextrin sodium sulfate, you allow them to recover, was a model developed by one of my colleagues, Dr. Christophe Altier. Now, this slide just kind of shows you the what we typically see in these mice. So in red, you've got a mouse that got that dextrin sodium sulfate for 5 days, and then that mouse recovered for 5 weeks. But when we put that balloon in the colon and we inflate it, that mouse has way more pain compared to a mouse that just got water the whole time. Okay, next slide, please. So as I mentioned, we're really interested in looking at sex differences in colitis. So here what we've done is we've got female mice that were given dextrin sodium sulfate and allowed to recover in red. And as you can see, these female mice have way more pain compared to control females who just got water the whole time in, I guess, dark red. And then when we have male mice that got dextrin sodium sulfate and were allowed to recover in blue, they have way more pain compared to their control counterparts in dark blue. But when you compare the males versus the females, you can see the females have far more pain when compared to the males. And this is despite the fact that actually when we looked at the amount of inflammatory activity, the females actually have far less inflammation when compared to the male mice, but they have far more pain. Next slide, please. So the next thing we really wanted to ask was, can we transfer pain by doing a fecal transplant? So are the gut microbes really involved in pain? So the way we did that was we did poop transplants, essentially. So we gave the mice water the whole time, or that dextrin sodium sulfate, and we allowed them to recover. And then we took their poop, and then we gave their poop to both germ-free males and females. So female germ-free mice got poop from both males and females, and male germ-free mice got poop from males and females. And then we tested the pain responses. Next slide, please. So this is kind of a complicated slide, but I'm going to take you through it. So at the top, you can see essentially mice that got poop from a female donor, okay, in panel B and C. And on the bottom, you can see mice that got poop from a male donor in panel D and E. So essentially here, what we've done is we've given female mice poop from a female donor. So when female germ-free mice got poop from a female mouse that got dextrin sodium sulfate and was allowed to recover, those mice had more pain compared with their control counterparts. And when we gave female poop to male mice, those male mice that got poop from a female mouse that got dextrin sodium sulfate and was allowed to recover had way more pain than those who got poop from a control female. So next click, please. So essentially, we gave female poop to male and female mice, and both of them got pain. Now, on the bottom, you can see when we gave poop from a male donor to a male mouse, those that got poop from the mice that were given the dextrin sodium sulfate and were allowed to recover had more pain than their control counterpart. But when we gave male poop to female mice, those recipient female mice did not actually develop pain. Next click, please. So essentially, when we gave male poop to a male mouse, it developed pain. But when we gave male poop to a female mouse, it did not develop pain. So this suggests that there's something about female poop, either the microbes or what they're making, that is very pro-pain. Or alternatively, there's something about male poop, i.e. the microbes and or what they're making, that is less pro-pain, or that the females are very resistant to the effects of the male poop. Next slide, please. And we found that the gut microbes are making different products from males and females. And now we're really looking at what role these different products have in pain responses. Next slide, please. So I hope I've convinced you that the microbiome might play a sex-specific role in the development of chronic pain and inflammatory bowel disease. Next slide, please. So really, where do we go from here? And this is just kind of stepping back and taking a look at things. Next slide, please. So I think really where we think this field should go is personalized medicine. Patients are different. No two patients are alike. Patients have different risk factors to develop chronic pain. They have different underlying diseases that affect different parts of their bowel. Patients have had different life experiences that might make them more vulnerable to developing chronic pain. Patients have different expressions and characters of their pain. And we can use things like that, as well as tools like looking at the gut microbiome, the metabolites that the gut microbiome is making, the proteins that are present, really to identify and group patients based on some of these unique traits. And the goal, of course, is to find good, unique treatment options that are tailored to fit each patient's specific need. Next slide, please. So the hope is when patients come to see me in my, IBD chronic pain clinic, rather than me throwing all these different therapies at you and kind of figuring out what sticks by trial and error. Next click, please. Hopefully we'll have much more personalized therapies. Next slide, please.
We're at the conclusion slide.
Okay, perfect. So I hope I've convinced you that chronic pain represents a significant burden to our patients with inflammatory bowel disease, and that the brain-gut axis really plays a fundamental role in chronic pain and inflammatory bowel disease in remission. And perhaps that therapies aimed at the microbiome might lead to new sex-specific treatments for chronic pain in inflammatory bowel disease. And as we've discussed, many of the therapies that we have right now are really extrapolated from patients with irritable bowel syndrome, as few have been tested in IBD patients who have chronic pain. Next slide, please. So I'd like to acknowledge all the people who've done the work, essentially. So in my laboratory, Maria Arzamendi was the one who did all the work about sex and chronic pain. But of course, all the current and past members of my laboratory are equally as important. Our collaborators in the Sharkey, Altier, McCoy, Göking, and Lewis labs. And of course, we couldn't do any of our research without the support of our funders, including Crohn's and Colitis Canada. So thank you very much, and I'll take questions.
Awesome. You also had this.
Oh,
quick-
yeah.
I'll leave it up while I wrap up. So wrap up the session, not the full session. So first off, thank you so much, Yasmin, for sharing your insights. And I thought there was so much parallel between what Alia shared and what you shared. All the different interventions, the gut-focused ones and the brain-focused therapies. So it's really great to see this overlap both in patient experience and in the research and your expertise. So again, thank you so much. We will now be moving on to the Q&A section part of the session. And I've compiled some of the questions that we received during the registration period that Dr. Nasser will now go over. And if you want to submit a question, there is a Q&A box found in the Zoom menu bar. So please share your questions there. We do have, this goes until 8:30, so we will answer questions until that time. We can keep going, but please feel free to leave if you need to. Okay, so this question actually came up quite a bit, which was, what is your opinion on using CBD versus THC for pain?
Okay, I would say this is a very popular question I get asked in my clinic. So I would say that IBD patients report that cannabis is very helpful for control of abdominal pain, diarrhea, nausea, and decreased appetite. Cannabis and cannabinoid products are generally well tolerated in IBD, although there's one study that showed that prolonged cannabis use, so more than 6 months in Crohn's disease, was associated with an increased risk of surgery. But the problem with that study is that we don't know the sort of cause and effect loop there. So we don't know whether using cannabis worsened disease and caused surgery, or it just reflects patients who have more severe or aggressive disease using cannabis in an effort to control their symptoms. Yeah. So in terms of pain and IBD, there have been a few studies. Actually, that's more been in IBS, I would say, the studies. So there's studies of THC, both a synthetic THC called dronabinol and THC itself. And in both those studies, they compared it to placebo, and they did that colorectal distension, just like we do in the mouse, where they stick a balloon in the colon. But they found that really there was no difference between patients using THC, the synthetic THC, or placebo in terms of pain. In terms of cannabidiol or CBD, there was a recent study where they put CBD in, I think it was a chewing gum, and they compared chewing gum formulation containing CBD versus a placebo chewing gum. And they asked patients about their pain. And when they did that, they really did not show any effect on pain. So I would say the jury is probably still out. Patients tell me every day, and I know that patients tell their providers every day that CBD or THC is helpful for pain. But right now, the trials have not been particularly supportive of that. In a mouse, it definitely works, I would say, but people are not mice.
Okay, thank you. The next question was, can hormones for menopause worsen Crohn's disease?
Okay, so that's a really good question. There was a study that was recently published out of McMaster, and in that study, they actually looked at oral contraceptives, which I know are not the same as hormone replacement therapy, but they found that oral contraceptive use increased the risk of developing IUD in younger patients. In postmenopausal women, there was a study that showed a relationship between the increased risk of being diagnosed with ulcerative colitis, but not Crohn's. And that was published kind of in 2013. But I don't think we know why and how that happens, I would say.
Thanks. The next question is, how do you relieve pain and gas in a J pouch? How can someone stop leaking and getting a bad nights of sleep because of having to go to the bathroom all night?
So I think there's a few components to this question here. So I think it's really important, first of all, to rule out a pouch-related complication, and also really looking at changes in the pelvic floor musculature, which can happen after a J pouch surgery. So if someone has pouchitis, which might be part of the pain and gas, there are some therapies for pouchitis, things like antibiotics, probiotics, or biologic therapies. Dietary strategies like the low FODMAPs diet can be helpful. Also, increasing dietary fiber can also kind of help thicken up stool and decrease the number of bowel movements that people are having.
The next question we had was, how can we be proactive to avoid IBS in addition to colitis flare-up pains that are debilitating and affect day-to-day quality of life?
So I think the very fact that you're asking this shows that you have a lot of awareness of sort of that overlap irritable bowel syndrome or that IBD chronic pain that can happen. So I think that's the number one thing is awareness. I'd say, if someone has risk factors like underlying anxiety, depression, adverse early life events, PTSD, to really being proactive about talking with your healthcare provider and your gastroenterologist about that, and being really motivated to just get on top of that and to seek help, kind of like Alia was saying.
Okay. Next question is, are you aware of any resources for biofeedback or strategies for dealing with the loop of abdominal cramping, leading to anxiety of needing to rush to the bathroom, which then seems to lead to stronger abdominal cramping?
Yeah, so I'd say really some of this is related to cognitive behavioral therapy. So in terms of resources, there's a website you can check out called thebreathproject.org. It's written and maintained by one of the gastroenterologists here in Calgary. It more teaches about deep breathing, meditation, relaxation, that kind of thing. There are some apps that can be used for cognitive behavioral therapy. I think Alia was mentioning one of them called Nerva. There's another one called LifeMD, which was developed by one of my colleagues, Maitri Raman. I don't get kickbacks for any of this. I'm just sort of mentioning names of apps. That one I know has a live therapist on there. And of course, working with psychologists in the community. Some of the psychologists work both remotely as well as in person. And the studies have actually shown that, sort of that telehealth and the in-person effect is very similar.
Awesome, thank you. And I think this was interesting because it kind of ties in with the example you provided in your talk about the potential individual getting anxious. And yeah, and also Alia has her own life coaching, which probably can help with the more mental, cognitive aspects of this answer. Okay, the next question we have are, what are some other options for pain treatment other than steroids? Can we find out where the pain is coming from and why?
Okay, so I think that this kind of comes back to that first slide there where I was talking about the general causes of chronic pain and inflammatory bowel disease. So if steroids are being used for pain treatment, it could be that somebody actually has active inflammation. So that's really important to, sort of treat active inflammation first or IBD related complications. And then, of course, we think about disorders of the brain-gut axis.
Next question is, what causes more intense cramping in IBD patients? Is it just inflammation?
Yeah, I think part of this is that whole brain-gut axis being revved up. And we know that probably it was the inflammation that kind of sensitized that whole brain-gut axis, but certainly things like, concurrent anxiety, depression, PTSD, they are all part of revving up that brain-gut axis for sure.
When mesalamine is failing, I'm not sure if I pronounced it correctly, but what are the next options? And maybe we can keep it a bit vague. I don't want to, because we don't want to get very specific.
Yeah, so mesalamine is a 5-ASA therapy. So when that's failing, the best thing to do is actually to talk to your IBD provider. So there's many other therapies to treat active inflammatory bowel disease, biologics, small molecules, immunomodulators.
Okay, thank you. What would you say are the top 3 things that are most important / most effective in minimizing pain? Is there a specific diet to adhere to?
Yeah, so we talked about the low FODMAPs diet, which you've mentioned there in your question. I would say in my experience in the clinic, the top 3 things that I've noticed that have worked for patients. So the low FODMAPs diet, I would say cognitive behavioral therapy. We're very lucky. We have a psychologist in our clinic that I send patients to. And I would say neuromodulators are also very helpful.
Thank you. Do you have 1, studies on the link between stress and disease onset, 2, studies on continuous treatments like Humira?
So I'm not sure what you mean by studies on continuous treatments like Humira. In terms of the link between stress and disease onset, so there's a couple of studies there. There's a researcher called Lori Kiefer. She works out of Mount Sinai. And she has really good data that psychological stress really worsens symptoms in inflammatory bowel disease. In terms of stress and inflammation, there was a really interesting study that was published by out of a group out of Pennsylvania by the last author is somebody called Christoph Thais, where they showed that stress hormones really interact with the gut's own nervous system to cause inflammation and bowel problems.
We also have some questions that came in while we were talking, so I can just go through them.
Yep.
Okay. Okay. Can you recommend a medication? Again, please don't answer too specifically, but I guess they're asking for a recommendation for joint pain in young adults on biologics. And can biologics still be continued when trying to conceive?
Yeah, so this is sort of a better question for your IBD provider and your rheumatologist. So I think that there are a number of medications that can be used to treat joint pain that are in terms of neuromodulators, if that pain is felt to be non-inflammatory, but then biologics do tend to treat inflammatory pain. Can biologics still be continued while trying to conceive or pregnant? So there's some good data on the use of multiple biologics in pregnancy. The only ones that are not should not be used in pregnancy are the small molecules, the JAK inhibitors.
So another question is, did you say convulsive pain is associated with IBS or Crohn's?
I'm not sure what you mean, Erin, by convulsive pain, but I would say that a pain that kind of, I'm not sure if you mean pain that comes and goes, but in patients with irritable bowel syndrome and inflammatory bowel disease, they can get pain that comes and goes.
Okay, another general question was, can an imbalance in hormones cause ulcerative colitis for an individual around perimenopause stages?
Yeah, so I think we kind of discussed that earlier. So there are some studies on the use of oral contraceptives as well as hormone replacement therapy. And these are epidemiology studies, so we don't fully have cause and effect, but it does look like there's some increased risk for Crohn's and colitis. But there's many other things that can cause Crohn's and colitis.
Okay. Another question came in, which was, is there specific support for help with gas pain / slow gut motility pain? Sorry, let me read gas pain / slow gut motility pain.
Yeah, so I think some of the drugs that have been approved to treat irritable bowel syndrome with predominant constipation can be used in that case, unless, of course, the slow motility is due to, for example, obstructions or stricturing type disease. So that's something to chat with your provider about.
And then another question is, what are your thoughts on Entyvio Q4W? I'm not sure what that means.
Oh, Entyvio Q4 weeks. So that's vedolizumab. That's one of the biologics. I'm not really sure where the question is coming from. It is a therapy to treat inflammation in IBD.
Okay, sure. Broad question, slightly broad answer. And yeah, sorry. And I think that wraps up our questions for the session. So again, a huge thank you. Sorry.
Convulsive pain was mentioned when discussing secretagogues as a treatment. Yes, I think, I don't know if this is a translation thing, but I meant anticonvulsants have been used to treat pain. So these are drugs like gabapentin or pregabalin. Yeah, sorry about that.
Awesome. Thank you. Thank you for checking in the chat and answering the questions, Yasmin. So again, a huge thank you to you again for being so patient, for putting the slides together, coming up with the content. We really do appreciate it. And very quickly, before we sign off, we will be now launching a post poll just to see, how your knowledge has changed after. Is it increased? Do you feel like you've learned more after the session? I'll leave it open for about 30 seconds. Okay. So that, and lastly, a special thank you again to Alia. Thank you so much for sharing. And this is something we're trying to incorporate the patient perspective into the GLS seminars. So thank you for attending and sharing your experience. We really appreciate it, and I really think it adds a different dimension to our talks. And then we also like to thank everyone who attended today. This is the last session of the year, so if you have any questions, please feel free to email them at learn@crohnsandcolitis.ca, and we will try to get back to you as soon as possible. And since this is the last session, I want to take this opportunity for everyone who's participated throughout the year. And thank you for being there and asking your questions and being curious. And also we want to wish everyone happy holidays and have a wonderful night. Good night, everyone.